Welcome. Today's session is about sarcoidosis, and sarcoidosis is a very important topic in USMLE as well as the Indian postgraduate medical entrance examination like NEET-PG. So without further wasting time, let us start with this topic. And as you know that sarcoidosis, the characteristic feature which is seen in sarcoidosis is non-caseating granuloma. So there is a collection of inflammatory cells like lymphocytes, macrophages, T cells. It is a one kind of delayed type hypersensitivity, but this granuloma will not show caseation in the center. That's why it is known as non-caseating granuloma, and it is a characteristic feature of sarcoidosis. But mind well, though it is characteristic, it is not specific to sarcoidosis. That means this type of granulomas are seen in other conditions. For example, mycobacterial infections, fungal infections, mostly systemic fungi, and some malignancy or tumors will show this type of granuloma. So that means it is not only seen in sarcoidosis, it can be seen in other conditions. Now this non-caseating granuloma, it is seen in more than one organs. So it is a multisystemic disorder where two or more organs are involved, or these organs will show this granuloma. Now the common organ which are involved, and out of which the most common organs which is involved is lungs. So this is frequently asked, and other organs which are involved commonly are liver, then skin, eyes. So these are commonly involved organs, but there are many other organs which are involved apart from eye, skin, liver, and lungs. Lungs are most commonly involved in case of sarcoidosis. So with this much introduction, let us start to see the other features of sarcoidosis. So what could be the fate of this non-caseating granuloma that you can see in sarcoidosis? So this non-caseating granuloma, in 50% of cases, or more than 50% sometimes, it resolves, or it will undergo remission, okay, but it will take years. So, and in 20 to 50% cases, that means in less than 50% cases, it can end up in chronic sarcoidosis. So non-caseating granuloma, in more than 50% cases, it undergoes remission in years, and in up to 20% cases it may develop into a chronic sarcoidosis. If we talk about the age group which is affected and the gender which is affected, so if it affects more than 40 years of patients, and if it affects less than 40 years of patient, that means younger patients and older patients. If it affects more than 40 years of aged individual, then male population is affected more compared to females, and in young individuals the females are more affected rather than male. So that is about age. So which one is more common? Usually the younger adults, they are commonly affected. Actually it has a bimodal peak. The first peak is around more than 80 years of age, and second peak is up at around 60 years or more. So both young as well as older individuals are affected. In younger individual, females are more commonly involved, and in older individuals, males are more commonly involved. So but this younger individual female, that is a more common presentation. It is associated with HLA-DRB1 1101 type. So it has a HLA association. Now, what are the types of sarcoidosis that you can see? So there are two types: sporadic sarcoidosis, which is seen very commonly in 95% of overall cases, and it is the most common type, sporadic sarcoidosis. But 5% of cases are familial, and this is very common, especially the familial cases. They're very common in Irish and African American individuals. So two types, sporadic and familial. Sporadic sarcoidosis is more common compared to familial. Okay, oops. So African American. Fine. So let us move ahead with our discussion. Now more to sarcoidosis. If we have to just see that what is the pathological hallmark of this condition. The pathological hallmark is non-caseating granuloma, and this we have already discussed earlier, that it is a characteristic finding, it is a pathological hallmark, but it is not specific or limited to sarcoidosis only. There are other conditions, where you can see this type of granuloma. So what happens? The antigen which stimulate the sarcoidosis, they are phagocytosed by macrophages or other antigen presenting cells, and as we know, there is macrophages or antigen presenting cells have one receptor known as MHC2, major histocompatibility 2 proteins, and which present it to the CD4 helper T cell, and this T cell will analyze the nature of antigen and it will release cytokines, especially the IL-2 and other cytokines. The macrophages also releases some cytokines, and the cytokines which are released from these macrophages, they are predominantly interferon gamma and TNF alpha. So together all these cytokines, interleukin 2 as well as the interferon and TNF, they attract more and more macrophages, more and more T cell, plasma cell, and they form a collection of inflammatory cells which is known as granuloma. Now this granuloma, if under the influence of IL-10, it will resolve, so it will undergo resolution. But if cytokines, there is the time, so IL-10, it will undergo resolution, but if it is under influence of IL-8, interleukin 8, or the TNF or endothelin, and all three of them, it will undergo chronic fibrosis. So there will be progression to the fibrotic condition. So this is the pathophysiology of sarcoidosis, that how the granuloma develops and how it will resolve or undergo chronic disease or chronic fibrosis or resolution. So we halt this discussion, and in next session we will talk about different clinical features of sarcoidosis.